1:40 in the afternoon. We have an informational hearing on healthcare market consolidations, impacts and costs, quality, and access. I want to welcome everybody. Today's hearing is it's just one of a series of hearings that the Senate Health Committee has been holding on cost controls. We've been doing them throughout the year, throughout the state, and obviously we're interested in understanding what the state can do to help control unsustainable healthcare costs. And when you think about covering California, when I speak to Peter Lee on a regular basis, he always tells me that the consumer's number one concern is obviously the costs of their premiums. It's critical that we look at all aspects of healthcare costs and keep our focus on affordable and effective healthcare. Individuals are mandated to have health insurance, and it's expensive. It's expensive for individuals to purchase, it's expensive for employers to purchase as well, and it's expensive for government to fund. You know, it's the biggest part of our budget. Healthcare eats up a large percentage of our state budget and takes away from spending on education, social services, and workforce investment. Millions have obtained health coverage because of the Affordable Care Act, which includes a major expansion in our Medi-Cal program. If we don't find ways to further contain cost growth, the coverage expansion will be unsustainable and premiums will continue to be difficult to afford. Now, today's focus is on price increases that come about from a lack of or reduced competition in the healthcare market and what the state can do to encourage more competition. I want to hear from all of our panelists today about what can be done, what is happening elsewhere, and if more should be done here in the state of California. We're going to be asking individuals to come up for public comment. We would ask that you sign up with a sergeant so we can determine who wants to speak. I don't know if this, yep, right over here to my right and to your left. We just kind of get an idea of how many individuals. We're going to try not to limit testimony. But, you know, we have hundreds of people, and we want to kind of manage the time, and we'll kind of give you an idea of maybe we may have to shorten ask you to shorten your testimony. With that, I'd like to welcome up the first speakers. We have, we're going to be talking about consolidating markets and strategies for lower prices. We have Paul Ginsberg, Professor, USC Price School of Public Policy, Director of Public Policy, USC Schaefer Center for Health Policy and Economics, and Schaefer Chair, Brookings Institution. Good afternoon, sir, and welcome. You know, before we get started, if you don't mind, I think Senator Nguyen wanted to just make a brief comment.
Yeah, actually, more of a question, if one of the panelists can address it later, Mr. Chairman, is I know that there's 3 major health plans that are being acquired pending right now: Centene buying HealthNet, Aetna buying Humana, Anthem buying Cigna. All 3 require some form of regulatory approval in California. However, it is my understanding that approving agency is dependent on who regulates the company. So during the hearing, if someone can please address what agency will be approving the agents, what agency will be the approving agency for each of the individual pending plan acquisitions. And might not be this first panel, it might probably be the last panel. But if whoever's out there, please help us address that later. Thank you.
And that would be the 4th panel, that's existing agencies authority, and we go over it. And obviously that's a concern that I have, because if you look at what's happening with the health market right now, there is a lot of consolidation. So consolidation could be good, but I want to make sure there's not unintended consequences to the consumer, because if we have monopolization, therefore prices could go up. Anyway, sorry for the interruption, and please proceed.
Yeah. I'm really pleased to be here, Mr. Chairman and Madam Vice Chair and members of the committee. I'm going to talk about when you find consolidated markets, what can you do to get more competitive pricing in those markets? And beginning, healthcare markets have become very extensively consolidated, and pretty much all of them. And this trend is accelerating in recent years. When you look at providers, it's an increasingly challenging environment to be a small hospital or a small medical practice. There are new pressures on payment rates, new contracting models to learn and try to thrive on, the transition to electronic medical records, And younger physicians want a different lifestyle. They don't want to start their own practice or join a small practice. They want to be employed by a large organization. If you turn to insurers, it's a very challenging environment for small insurers. Multi-state employers prefer national accounts. This means that their business that regional insurers used to be able to compete for, they often cannot. There are scale economies in building the analytic capabilities that we want insurers to have. And also scale is needed to contract with providers using alternative payment models. You have to have enough patients for the provider to be interested in working out a relationship with you on this basis. So the implications of these trends is that consolidation will increase further, even if antitrust enforcement is vigorous. And from my perspective, you need public and private initiatives that go beyond antitrust to foster competition on price and quality. Now, in the insurance market, we have some tools that have been, I think, been successful in fostering competition, and I want to highlight the public exchanges created by the Affordable Care Act and private exchanges that some large employers or small employers are experimenting with. Insurance exchanges reduce entry barriers into local insurance markets so that a plan doesn't have to spend as much to build a brand and to get access to potential customers as it would have before exchanges. Exchanges can support consumer comparison of plans so that they can make better choices. Exchanges have found that there is a need to improve their risk adjustment approaches, and that's going to be a project of the next few years. I should say that Covered California is really a national model of what an exchange can do to make insurance markets more competitive. I'm going to be focusing most of my statement on provider competition, though, even though you do have the insurance mergers on your minds. I actually think that the downside of not having policies that foster competition with a consolidated market may be even more pressing in the provider market. So in the provider market, for one thing, you need a broadening of antitrust policy that I'll get into in a minute. You do need policies to foster market forces, and if all of those fail, we'll have to contemplate direct regulation of prices. Now, as far as broadening antitrust policies, there are two areas that at least national antitrust enforcement has not addressed yet, but which is becoming more important. One is hospital ownership of medical practices. Basically, it's pretty clear that when hospitals employ physicians or buy hospital medical practices, one of the results is higher prices for physician services to purchasers. And a research literature to support this has been developing in recent years. I suspect the reason that antitrust enforcement has not gone into this area is that it's awaiting a fuller literature to back it up. Also, hospital ownership of practices leads to barriers to steering patients to high-value providers. Employed physicians are going to refer patients to other physicians or the hospital that employs them. Also, it reduces the potential for competition in a reformed payment contracting market. So there are fewer entities that can possibly contract on a bundled payment basis as an accountable care organization. The other area is cross-market mergers, so that a must-have hospital, which to me means a hospital that is so prominent and has such a sterling reputation that people don't want to buy insurance that does not include that hospital in the network. So under cross-market mergers, which are mergers of where a hospital system acquires hospitals in various discrete markets, sometimes the must-have hospital achieves higher rates for the system hospitals in other markets. The agencies to date have looked at markets separately and not in a cross-market way. I want to first discuss something that often comes to policymakers' minds about making markets more competitive, and that's transparency, price and quality transparency. And more transparency is a societal value in this country now. We have belief that major institutions, public and private, need to be transparent in their operations. But transparency is often oversold as a strategy to foster competition in healthcare. And here are some of the reasons. Many benefit designs have few incentives to choose lower-priced providers. So often they'll use co-payments where the patient pays the same amount for a service no matter what the physician's price is. They'll use co-insurance, which means that the insurer is paying most of the difference in price between two providers. So some of the designs don't foster that. Even high-deductible plans, which are seen as the ultimate in fostering competition, need for price data, often is not useful for inpatients, because anyone who's admitted to the hospital is likely to exceed their high deductible, no matter how high it is, and many of them will exceed their out-of-pocket maximums. Thus, it doesn't matter to patients if they go to a less or more expensive hospital. I also think that transparency is oversold because, all the work that a consumer has to do in looking at data for different prices can be a heavy lift for many of them. And there are many services where there's really no time to make these assessments. I've seen some excellent price tools available now from insurers and employers, and those excellent tools consistently report getting very little use. Quality transparency is an aspiration for the future. It's going to make a big difference when it comes, but I believe that quality transparency in a way that consumers can use it is some time off. Now, I want to put a lot of emphasis on network strategies because I believe that this is the most powerful tool to make healthcare markets more competitive, especially consolidated ones. The concept here is that the insurer is acting as the purchasing agents for those who enroll in its plans, whether they're the employer or the employee or the individual consumer purchasing on the exchange. And network strategies work by shifting volume from high-priced to low-priced providers. And there are three potential sources of savings. One, the simplest one, is that a higher proportion of care can be delivered by the lower-priced providers, and this will save money. In addition, a network strategy will achieve discounts from providers seeking inclusion in the network or in the preferred tier of the network. And finally, if enough providers are in the situation, it's going to lead to stronger incentives to control costs. I think network strategies also offer a very strong potential for using broader measures of price and to incorporate quality. So instead of looking at just unit prices, you can look at prices per episode or even prices per patient, per year, or per month. And, when you think of the alternative payment models such as ACOs or bundled payments, there are strong analytic parallels between metrics that insurers can use to assess providers for networks and what's used by public and private payers to pay in a reformed way. Also, network strategies open the opportunity for greater integration of payments and delivery, so that we're seeing now, in response, more provider-sponsored plans, and I've seen a lot of these around California, either on their own or as joint ventures with insurers. Now, there are two types of network strategies, a narrow or limited network versus a tiered network. And the narrow networks are the more powerful tool. There are very strong patient incentives for steering. And the attraction for patients, or for consumers, I should say, in enrolling in these plans is a large premium reduction. various studies by McKinsey and Company of the experience with the ACA marketplace plans is about 15% lower premiums for those with narrow networks than for those with broader networks. And the exchanges have provided an ideal environment. The fixed contributions mean that consumers have strong incentives to seek lower premiums and perhaps accept less choice. On exchanges, there isn't a one-size-fits-all requirement that many employers feel constrained by. What I mean is that you can have a plan that appeals to maybe half of the potential market in the exchange, and that plan can be very successful. If an employer had a plan that only appealed to half of the workforce, that would be a big problem. And finally, exchange tools can facilitate the consumer comparisons of networks across plans. Just going to one place, going to the exchange, seeing the networks of the plans that you're considering is a huge asset for consumers shopping in this market. Now, turning to tiered networks, and a tiered network is an arrangement where the network providers are sorted into a preferred tier and one or more additional tiers, and the consumer pays less in the way of patient cost sharing if they go to the preferred provider, the providers in the preferred tier. So this is a point of service choice as opposed to a once-a-year choice that is made, that consumers make when they sign up for a narrow network. This is a point of service choice, and when you think of the degree to which PPOs have been more popular than HMOs, and tiered formularies for prescription drugs are much more popular than closed formularies, you can see the potential of the tiered approach. But we don't hear about tiered networks, and why? I think in many areas they have not been able to develop because dominant providers have blocked them. Basically, the providers have said, unless you place me in the preferred tier, I won't contract with you. Fortunately, 2010 legislation in Massachusetts, which the next witness might go into in more depth than I can, appears to have opened the door to tiered plans in the state by prohibiting that practice that I mentioned. Now, there's been a lot of work in California that's gotten a lot of attention on reference pricing with what CalPERS has done in partnership with Anthem. Basically, reference pricing, which means that the a price is set, and for providers whose price is above that, the patient has to pay the difference between the reference price and that provider's price, in addition to regular co-payments and co-insurance. And there's no change for providers whose price is below the reference price. So what reference pricing really is it's an extra strength tiered network approach. It is a tiered network approach. These providers are all in the network, but those below the reference price, in a sense, are the preferred tier. But the penalty of using the providers above the reference price out of the preferred tier is stronger. One of the advantages of reference pricing is it's a relatively simple choice for patients. All the patient needs to know is, is this provider's price below the reference price? And CalPERS has had a lot of success with joint replacement and some other services. But the big question going forward is to what proportion of health spending is suited for this approach? Joint replacement was very successful. What percent of their spend did they save? I don't know, it was 1% or something very small. And this brings up the concept of shoppable services, meaning what proportion of healthcare spending is in services that are shoppable, where patients have time to make these choices, and where the choice is somewhat independent of other services. Some work done in my previous think tank estimated that about a third of services might be shoppable and thus amenable to the reference price approach. Now, there are some serious challenges for network approaches. For one thing, clearly there's a need for better transparency about the networks, the basics of which hospitals and physicians are in the network and which are out of it. And we need this information when consumers make choices of plans, and also during the year when consumers are making choices about providers to use. That has to get better. Also, network adequacy requirements need to be enforced, but they need to be wise. There needs to be a balance between the cost-saving potential for narrow networks and the prevention of risk selection of insurers having a plan that doesn't have specialists in high-cost diseases, and for consumer protection. I believe that for many of the network adequacy issues, like having the right subspecialists, a speedy and fair appeals mechanism is a very important complement to network adequacy and to address that part of it. One thing I want to mention is that we hear a lot about surprise balance bills, meaning balance billing by providers that patients do not choose, like the physicians in the emergency departments or an assistant surgeon. And I think this is a serious issue, but it's an issue for broad networks as well. So it's not really an issue specific to narrow networks. There are some other steps to foster competition. A number of public and private payers have been taking steps to deliberately foster independent medical practices. Medicare has made it easier for a medical group to contract with it as an accountable care organization. Some private payers have helped medical practices with their IT and other infrastructure investments. There are additional anti-competitive behaviors beyond what I referred to as the anti-tiering before that can be addressed. One is all or nothing requirements, the ability of a hospital system to require health plans to contract with all of their hospitals is an anti-competitive procedure requirement and could be addressed by policy. And also most favored nation clauses, where the provider agrees not to charge other payers less than the amount agreed to. There are regulatory alternatives to these efforts to increase competition. Some states are contemplating rate setting at the moment, mostly in the Northeast. There have been some successes in the past, but using rate setting in 2016 has some additional challenges. For one thing, there are large differences between commercial, Medicare, and Medicare rates that are not likely to be changed. They're going to have to be grandfathered. Or rate setting can regulate only commercial rates, as West Virginia has done since it began rate setting in the 1980s. Rate setting also needs to encourage payment reform rather than block it. Maryland has a very promising attempt to do this, and they got a significant waiver from the Medicare program to continue to include Medicare payments under their rate-setting system with this new initiative. But the question comes up, where rate-setting historically has been for hospital rates, and now that so much reform in payments is focused on multiple providers, on different providers working together and sharing risk, can these mechanisms, either work by only applying to hospital rates, or is it feasible or desirable for them to become broader as well? Here's some thoughts about possible legislative priorities. I really have two. One is to focus on restrictions on anti-competitive practices, such as preferred tier placement demands, most favored nation clauses, and all or non-contracting requirements, And the second one is to regulate network adequacy wisely. It's a potent tool to foster competition, even in consolidated markets. So the challenge is to address the problems that it's experiencing while preserving much of its potency as a price containment. And as a concluding thought, payment reform is likely to contribute to consolidation. And my perspective is that we shouldn't not pursue payment reform for that reason. I believe we should proceed with the payment reform, but broaden the enforcement of antitrust policy and pursue additional policies that foster competition. And that rate setting should be seen as a stick in the closet to use if market approaches fail. Thank you very much.
Thank you. Do we have any questions from any of the members? Yes, Senator Pan?
Thank you. Thank you, Dr. Ginsburg. Appreciate your presentation. And appreciate your statement about physician-owned practices being actually more expensive. I did want to ask about, you said obviously network reform, and you talked about that as a mechanism, and narrow networks, and certainly I think there's, narrow networks has been a tool to try to restrain cost growth. There's also been a lot of conversation about, provider supply as well, physician and other healthcare providers. And in many ways, plans, when they have narrow networks, aren't contracting, therefore, with all the providers who are available, yet where you keep talking about a provider shortage. Do you see, from your perspective, the claims of provider shortage perhaps to be somewhat questionable if plans are having networks that are actually smaller than the provider supply, and if those are considered to be adequate? And I know you try to address the issue about network adequacy. If you have many providers out there who want a contract, yet you can't get a contract, does that speak to the supply of providers? Now, again, I realize there's different geographies and so forth, so it's not, we don't have a homogeneous supply situation across the state.
Well, I think the physician shortages specifically, it depends on the specialty. Mm-hmm. Certainly primary care, psychiatry are, perhaps in greatest shortage, and I would expect.
Although not every primary care doctor can get a contract.
That's right. I was going to say, I would suspect that, in a sense, it's easier for a primary care doc to get a contract than for physicians in some other specialties, just because they're in shortage. And also, I don't know how extensively they do it today, but, what plans spend for primary care physicians is very small, a very small part of their spend, to the degree that having good primary care physicians can probably save them a lot of money. So I would think that, plans would be foolish in, constraining the primary care capacity of a narrow network, except insofar as trying to sort out between primary care physicians they think highly of and those that they don't.
Okay, so it's certainly, and that's on one level, and I've certainly heard, even in so-called shortage areas, that they're not contracting with all the primary care doctors even that may be interested in contracting. So even if that's not necessarily a wise strategy from your perspective, from the health plan's perspective. And then I guess the other question is that could it be possible that sometimes their contracting would be a secondary way of redlining certain neighborhoods, because people usually want to find a physician that's close to them, particularly primary care, actually, more so than perhaps specialty care, where people are larger areas, that by essentially denying ready access to a physician in particular neighborhoods, there may be neighborhoods where, because of various reasons, poverty, other things, where utilization could, or potentially could be higher, or their demand for services may be potentially higher, I should say, because of that. And is that something we should be concerned about when we look at network adequacy?